um, it becomes a bit of a problem, and you can like get even better at doing it and better at communication. But if there's literally nowhere to put, like, there's some of the clinics we work with, they have like a 2 day wait list. Like they can't actually, they've got like 15 people on their wait list and stuff. It's like,
It's certainly, I don't know, it'd be interesting because I can't remember when we implemented it, but yeah, it's like the past 10 weeks, it's just found a new normal, I reckon, eh?
yeah.
That's what it looks like. So, huh,
And have you got, what about hiring more staff though, Dave? That's the next thing.
yeah.
No chance?
No, it's not no chance. I think probably have to put, it depends what you just knowing the metrics for when it's the right time.
Yeah.
That's the thing. And it's just, it's when it's the right time and it's also the right person.
Yeah.
Because it's got to be the right person for us.
Oh yeah.
It would just take one numpty to fluff it up, eh?
Yeah. Yeah.
We've already got Jeremy.
Yeah,
I was gonna say, yeah. The beard's like written warning level.
It's almost getting, to be fair, he's getting a bit ZZ Top at the moment.
He's like ZZ Top, yeah.
Yeah. ZZ
Yeah.
Top's homeless and hadn't hit
Yeah.
record.
ZZ Top's like estranged homeless cousin.
Yeah, but with regards to staffing, it'll just, I think, yeah, it's the right person at the right time, eh?
Yeah. Yeah, I
So
think so.
I could see it happening, but not, yeah. It has to be the right person.
Yeah. Yeah, that's for
The
sure.
policy, you see.
Yep. Now is there anyone else coming or are we good to go?
Thanks, is it? Yeah, Tim's not here. We can talk about him and his Hobbit feet.
Oh yeah, okay. Well, he's pretty clean. He's like much more respectable, clean shaven, you know. Um, all right. So something which I use a lot, which we haven't done, which probably will take we'll do today, and then we'll probably need, I reckon, at least one more 2 hours some point. Um, because it's like a workshop I do, but it's we'll do mostly practical today, but there's a bit of theory I just want to do at the start. It's motor control. Like basically, how do you get patients to retrain how they move, and what are the optimal ways to do that? So this is stuff I learned. Um, like there was quite a big research shift probably around 15 years ago, which is simultaneously when I did my master's. And there's stuff I learned then that has completely changed how I treat patients for the better. And I'm assuming you guys do a lot of back, like a lot of low back.
Yeah.
Yeah. So this stuff is like some of it you may have heard of, hopefully some of it's new. And there's recent research which is like proven that it's best. Um, so we'll do a bit of theory and then we'll do prac. But um, so it's like, yeah, how do you best show a patient that their posture is linked in with their pain, and is it possible to change that? And I think a lot of the times there are. And there's like quick little hacks that, similar to some of the stuff we've done with you guys. There's like quick little cues and hacks and strategies you can give to like get the patients better quicker probably and get them in control more. Um, does any of you guys have back pain or not? Like low back pain?
No.
No. Okay, that's cool. Thought I'd give it a try. Um, let's start with me. All right. So I'm going to tell you my story. I'll tell you my story. This is me, my actual story. When I was 13, I was a emerging fast bowler. Because I'm 6'3", and I was pretty quick, like for a 13-year-old. Not that good, but I thought I was good. But one day when I was bowling, I I broke down in the middle of the pitch. I couldn't get up off the ground. My back was in agony. And then I tried to bowl a few more balls and I just stopped after my over. And then I was due to come in next to bat about a few hours later, and I couldn't even stand up. I was crying because of how sore my back was. I went and got it x-rayed through a GP. It was fine. And then for the next few weeks, my back was really sore at night, would wake me at night. And then I actually was also doing athletics at the same time, like um, training for the cross country and champion boy, we used to call it, where you do all the events, the athletic events at school. So I actually won champion boy with my friend. We won together, and I was in agony with every event, and I just kept pushing through. And then it slowly settled a bit, but every time I'd play sport, my back would be really sore after, and it would hurt that night and the next day. Right? So that's not me, but you can picture that's what I used to look like. Um, Sore back, champion boy. But what do you think if you had a differential diagnosis, what would you say was going on with me?
Fracture.
Stress fracture?
Yeah, pars fracture. Yeah.
Any other takers? What about differential diagnosis? What's your differential diagnosis for me?
I've got like fast bowling, extension, side flexion, so maybe an active extension pattern sort of thing.
Yep.
Just limited to the lower back, one-sided,
It was bilateral.
bilateral. Yeah, it's still go down the pars fracture thing, but yeah, it's an extension side flexion, so it's an extension-based pattern problem, I would have thought.
Yep. Yep.
So I'd be sort of hitting first before anything else. Maybe SIG component, but unlikely, but possible.
Yeah. Especially, I definitely wasn't pregnant.
Yeah. So you're
Yeah.
just not a sensitive individual.
So then what happened? I kept playing sport because I'm like any most young physio or aspiring. It's kind of sad when you get to your mid-teens and you realize you're not going to be a professional athlete. But anyway, um, I kept playing sports probably 2 hours a day, maybe 3 hours a day, as most boys do. Um, got to uni. The tutor was like pushing on my back, and she got down to L4. Like the upper lumbar was fine. Got down to L4. I was like, that's really sore. Like that feels like maybe I'm weak, but that feels incredibly painful. And then they pushed to the level below. So this is like 7 years or 6 years later. And then I just said, like, you have to stop. Like, it's actually getting worse the more you push. And she goes, you need to get an x-ray. Something's wrong. And it showed bilateral full thickness pars fractures and a spondylolisthesis grade 1, 2. The GP said to me, you've got stress fractures and a slip vertebrae. Do some hydro and do some physio. Now, I went to the physio and he gave me like core exercises, bird dog, fallouts, you know, bonafide planks, that kind of thing. Multifidus retraining. My hospital mentor, because I worked in a hospital like shortly after graduating, he said, don't ever run again. And he said, don't lie on your tummy. So then I stopped playing sports. Okay. What do you think of that advice so far?
The GP was sorry.
I was gonna say, GP's not terrible. Like talking about,
Maybe
you look high, that stuff.
could have
Could
delivered
be
it.
worse. Could be worse. Yeah.
Yeah, could have delivered that better.
Yeah.
I don't agree with hospital Meta. I think they were probably catastrophized and maybe put you down the wrong path by avoiding stuff.
Yeah, exactly. And I did. It literally like because I was like very active. And I probably put on a bit of weight as well, correlated to that, to be honest. Yeah. What else? Anything else? So then,
Yeah, it's just more, I think it's just more the delivery of the message from the GP, and it's like it's whether what you were told by the hospital mentors that's what you heard or that's actually what they told you. Yeah.
yeah,
That information was
maybe I
first received,
misconstrued it.
and it's first up was the problem.
Yeah.
Or is it
I might have misconstrued what they said, but that was the impression I got.
yeah.
And then I did my master's, which I was saying before in 2010. Um, and then Peter O'Sullivan, who's a professor of back pain, he's quite famous in physio circles if you haven't heard of him. And he said, well, because like the whole one of the focuses of the masters at Curtin University at that time was about how little what the scan shows correlates, which we've gone through with you guys, but including pars fractures, once complete. Okay. And then Pete said to me, well, actually, there's no evidence that shows. So he got me up in front of the group because he picked someone out of the crowd and he goes, who's got back pain? I put my hand up. He draws me up in front of the tutorial, which was like 40 people. And I just told him what my situation was. And he goes, well, there's actually no studies that show running makes a spondylolisthesis worse. And he goes, there's also heaps of athletes that have them and they run around and they're fine. And so when he said that to me, it was like he pushed a button in my mind. And I was like, okay, I'm all good. So I went out and ran that 8K that weekend. And guess what? I was fine. So, what do you reckon? If you think back to when I was a teen to the end, what do you think's some of the morals of the story?
GPs are idiots. Nah,
I guess it's like that people take what you say and they'll remember it, especially if it's that kind of fearful kind of stuff,
Yeah.
and they'll run with that as long as until someone tells them otherwise, I guess.
Yeah. Yeah. Like, I mean, I consider myself to be fairly intellectual. And I was like, I just followed the advice. I didn't really question it.
that's the other thing. You don't treat yourself because we're useless at treating ourselves.
Absolutely. Yeah.
Yeah, yeah. I guess the other thing, the moral of that story is like, yeah, you've got an acute problem that wasn't managed well acutely. And
That's very important. Yeah.
basically what Peter, I would imagine, a query I have is like by the time you've seen Peter Sullivan, he said his stuff, you've got, how would I put this? The structural issue is probably resolved nicely, but that sensitivity is maintained, plus all the other sort of effective components. And the way he delivers it's like, that's going to flick that switch off.
Yeah.
But that turns that sort of turns that component round, I think. That's
Yeah. It does. And the thing is, I should what because I had an X-ray, I remember when I was 13 and it was clear. What should have happened is I should have had an MRI expedited because in my case, I should have been given 12 weeks rest or relative rest, but I kept playing. And so what I've seen since then in practice, I've probably seen maybe 20 young boys and girls who play sport with an extension bias, which is exactly what Dave's saying. They come in with severe back pain. They're coming for second opinion, remember? And I say, go get an MRI, and they've got a start of either a stress reaction or a partial pause, and they need to stop because if they keep playing, it'll progress. Now, some of them, once they've progressed, will become asymptomatic. That's fine. But if someone's got a fracture, you're best to let it heal. It's a specific problem. Most of what we see in private is not that, but there are cases where we have that. And so, for example, I had a cricketer late last year, had been seeing a chiro who'd been doing high velocity thrusts. The kid was in agony, couldn't extend, couldn't side bend at all. Went to push on his L5S1 on the one side. On both sides he was sore, but particularly on the one. I tried like a few just repeated mobs, like maybe 10 seconds, was getting worse, even just like a grade 3. Sent him for MRIs, near complete pass. Gave him 12 weeks, did another MRI, healing. He could still cycle around, he could still do hydro, but he had to stop sport. Because that it's like if you're running on a stress fracture on your foot, it's not going to heal. So it's difficult to do though with a young person. And the parents sometimes as well, because the parents can be like, you know, when are they ready? Whereas the dad in this recent case was like really good. He's like, I'm happy to take him out for a year. I wish someone had done that with me. Like my back's pretty good now. Like I'm fine, but I still get sore. Like if I stand for ages, it's still sore. If I still play sports now and then. If I play sports, I'm sore the next day. So I think the very key first message is, as you said, Dave, like if you can avoid making actual pathology worse, we should. A lot of the time, you don't want to scan people with back pain. It doesn't help. It creates more problems. We've done disc before, but even for just general back, getting the MRI does not help unless it's something like this. It's like you have to. I had another case the other day, a second opinion, with a GP who'd been seeing another physio. Um, and it was a young girl, like 15-year-old, and she had disc signs and symptoms. And the GP was just like, "Oh, she's fine." And I said, "Well, actually, we probably should just," because I tested her um, ankle reflex and it was absent. And I was like, "Well, we should probably we should probably just do an MRI just to see what the prognosis is, like how long we're talking." And she had like a 10 centimeter disc bulge. Sorry, 1 centimeter disc bulge. So yeah, I think, and that's I haven't seen too many of that in kids that age. Yeah. What do you guys think about what I'm saying?
Well, it's funny because I just had a triathlete this morning who had a sacral stress fracture, which she's rehabbed from, and she started to get back pain. Now she's gone back to training and she's freaking out.
Yeah.
I've just assessed her this morning and I'm trying to convince her, going, I don't think this is a stress fracture. I think this is just some SIJ lumbar extension stuff.
Yeah.
I think what she's been told in the past hasn't been great.
Yeah.
But I think maybe, yeah, I don't think the communication at the early stage has been particularly good for her. But it's trying to convince her at the moment and sort of demonstrate, going, this is why I don't think it's a stress.
Yeah.
And this is where we go from here, and this is how we go.
Yeah.
But yeah.
So basically, as we spoke about when we first started doing these sessions, right? It's like we're never going to get around it. Like in 10 years' time, in 20 years' time, I'm telling you, the patients want really, really clear information, direct time frames. They love it. I wish someone had got me and sat me down and said, Kieran, you can't play sport for 3 months. I would have said, that sucks, but at least I know because I can, I've got an endpoint. Whereas I had no endpoint. You know what I mean? And then I think some of the nocebo didn't help, but then also it was good to get that positive, it's spun in the positive as well. So if we like, I was this or red flag. When someone comes in with low back, immediately my head goes to this. It goes, is this someone who's got massive neurological specific structural problems, e.g., disc prolapse, which we've discussed before, central canal stenosis, high-grade spondy, or are they like malignancy, inflammatory disorders, infections? But you know the percentages are low. We're talking like, you know, the absolute minority. Most are going to fit into this like, there's not anything structurally. If we MRI them, it's not going to help. It's the opposite effect. So as long as we clear these, we're stuck with that sort of non-specific, quote unquote. Um, then you just quickly you should always do a quick psych screen, like how concerned of this are you? Is it affecting, do you think your thoughts are changing how you move? When you feel pain, do you stop? Those couple of quick questions like that. Or you can give them the short form Orabro if they're compo, or if they're like a really hard um, second opinion.
Would you
If
that would you do that in the first assessment or would you do that in the fall?
I do it, any compo, I do it homogeneous.
See some non-compo like that.
Non-compo, complex chronic second opinion, I would do it in the first session.
It's sort of like, say, how would I describe it? Not vanilla, but your mechanical low back pain, come off the street, maybe have pain for about 2 months.
Yeah.
Because would you not more just assess first, try and work it out, see if their first visit, see how they respond to their first visit, and then sort of just gauge, is it do we need to go down that line? I don't know. What's
There's arguments either way.
yeah,
You could do, if it's non-compo, couple of months like that.
yeah,
What my professor from the masters, she said that basically something happens between 6 to 12 weeks, obviously,
yeah.
when they're subacute. There's something that's going on that's making these people progress to chronicity. And it's probably highly psychological. So you can do either, Dave. Like you can literally just ask them all like the relative questions that are on the Arebro. How long do you think this is going to take to get better? What do you think's going on? Um, do you believe it's structural? Do you feel like you need an MRI? Um, do you like, are you protective of your back like that? You can ask them those sorts of questions, or you can just do that at the end of the first session or the second session. You can give them the short form Orabro, which takes like 2 minutes. If the cutoff is over 50, you have to spend probably more time educating them. Because if it's over 50, they're at risk of persistent
Yeah.
problems because of the psychology. Some patients, it's like 20. Like I had a guy yesterday, he was like 20. He's back at work. He's like, he's compo, but he's back at work. He's like, no, he's not, he doesn't, he's like, doesn't worry about his pain. He's fine. But some patients, they're like really stressed. And it's all the same stuff. Like they think it's never going to get better. They think if they feel pain, they should stop. They think pain causing damage. They're depressed and anxious because of it. If those features are very high, we have to spend part of the time talking about that. Another key thing, just from this like introductory part, the there there is always a psychological component, always, every single case, especially with back, but it's never not. It's just how much. Sometimes it's like next to nothing, but then sometimes it's dominant. So I'm always, whenever I'm doing an assessment, although I love manual, I'm always thinking like I have to spend at least part of my first session just educating them, and most likely de-threatening, unless it's something like a stress fracture or massive disc prolapse that's giving them neurological compression. What do you guys think of that?
It's just a bit of a balancing act in private practice. I don't think a lot of people, nobody really comes through the door wanting to be educated. Like they're looking for
No, no, they don't.
it's how you mix it all together, isn't it?
I think so. Yeah, because you don't want to become like the problem with this approach that I'm talking about is sometimes it gets too psychological, and the physios are like trying to use like explain pain and stuff, and the patients don't really need it.
I think it's just little nuggets you need to tell them, right?
Yeah. Well, I'll show you some of those nuggets now. Um, so where is it? Get rid of that. What do you guys think of core stability?
From what era?
Uh, 20 years ago.
Wasn't a fan.
You weren't a fan.
I just when it was first talked to me, it was like everybody's doing 4-point kneeling and transversus abdominis, and it was like bollocks.
Yeah.
Because half the time I used to think that all you're doing is you're offloading people, so they're probably resting up, and it's like it's settling down anyway.
Yeah.
There's maybe a few people that it's worthwhile doing, but yeah, I was never really sold on it hugely. Yeah.
Well, I was the same, and I was trained in real-time ultrasound. So I can actually do it, like the multifidus thing, and I can do the bloody drawing in the abs at 20%. And when I was doing it, I was thinking this isn't doing anything. But I would give it to them. And there was actually some studies. There's a paper, Ferreira, where they did it and the patients got better. But then they compared it to doing just general strength training and they also got better. This is for chronic low back pain. And then they did like functional motor control and they also got better. So it probably does something. But I agree with you. I think it's like a bit of a like just I used to think it's like piddly kind of not really doing much.
I guess I think there's elements I would probably take, but the other thing is that there's exercise works on multiple levels, and that's the other thing for me. It's finding what works for the person in front of you.
I think so. Yeah, that's kind of what we'll get into, which is like basically subclassifying the patients. Do you think, have you guys read this paper?
No.
I have, yeah.
Okay, if you haven't read it, I'd strongly recommend you read it. It takes like 10 minutes, maybe 15, maybe a bit longer, 20. But it's like really good. They kind of question, but some of the Queensland physios don't like it. They get a bit triggered because they criticize Paul Hodges a lot, who's quite a big deal in Queensland. And they just basically say that this idea of core stability came around like kind of 50 years ago, but they didn't actually really test it that well. And so they found people with fatty infiltration in multifidus, fatty infiltration, a delayed timing of transverse abdominis. And so they, by deduction, said we need to then give these people multifidus and TA co-contraction. But they talk about how basically it's a fantasy because you can't get people co-contracting 24/7 because it's neurologically impossible to just co-contract TA and multifidus. You will always recruit something else. And typically what you do is you over recruit rectus and pelvic floor. And then what happens is the patients become hypertonic. They're too braced. They're too erect. And then it it all feeds in. Can I show you this video clip?
Good.
All right. I'll just quickly find it. It's like it probably goes for like 5 minutes, maybe 10. This one.
Oh, that's what I'm seeing.
Have you guys seen this one?
Do that.
Why isn't it working?
Looks
Hang
like
on.
Mick from Simply Red.
What was that?
From Mick Hucknall from Simply Red is on Peter Sullivan. I think it's what you were just saying is like I've got a bit of a bias towards Stuart McGill stuff or like disc rehab.
Yeah,
But in his course, he was talking about like the cult of planking. And it
yeah,
was just basically planking for too long. And he says one of the things that people forget, and he like from physiological point of view, is you're asking a muscle, you then start training a muscle to do what that muscle system's not supposed to do. So it's
yeah,
supposed to hold you in that position for 5 minutes at a time.
yeah,
You're actually metabolically, you're changing its characteristics by some of these sort of training things going in. And I was like, all right, that's quite interesting. So he was very much, you've got to learn to train these things for the role they're supposed to do. And it's not just purely sustained stuff.
yeah.
I thought it was quite an interesting slant on it.
I think that's a good way of thinking of it. Yeah. All right, hang on, I found it. So just one sec. Um, the only thing is, it's just not for some reason. I can send it to you. I don't know why it's not working.
I just sent it because I have seen it. It's on YouTube, so it is worth watching now.
Oh, it's good. Basically, because the thing is, I give it to patients, right? It's Pete, that professor that I was telling you about. He describes that basically because of core stability, this concept, a lot of patients and therapists get the patients to do core, but they overshoot. And so the patients hyper brace, and their hyper bracing causes them to have ongoing pain. And so he shows these clips. Just remind me, I'll send it to you after. It's awesome. He shows these clips of like 3 different patients or 4 different patients, and they're all sitting bolt upright like this in the assessment. And then they are told like your back's never going to get better. Your core's too weak. So they keep going up. And then some of them are told like even more negative, like you're going to basically die with your back sore. One of them said the last guy, the GP said to him, the last guy who came in with this had cancer. You should never run. Like all this negative stuff. And then Pete shows them that if he gets them to relax, they actually become fixed. So he follows them up a year later, giving them all this advice about like more relaxed movement. And it's quite cool because like in the start, it's like all this somber music, and the patients are like, I became suicidal. Like I thought I was never going to get better. I was on opioids. I was told I needed a fusion. And then he follows them up a year later with like all this hope-filled music. And they're like squatting, jumping, running on the spot. They're like, I'm totally fine now. My back's gone. My back pain's gone. And I've showed the video to patients, and they often start crying. Like they're like, that's me. That's what I was told. So there's a couple of other resources I give patients, and you can still get them into Pilates, you can still get them into your gym setup, but it's just trying to identify the ones who do need core, quote unquote, and the ones who actually need to relax, and the ones who maybe need to like be more aware of their pelvic position. So I'll show you those main ones today, like how to subclassify them. So I learned this stuff like 15 years ago, and like I've never looked back. It's like totally changed how I assess and treat backs for motor control, which I'll show you. But on the core thing, do you guys think anyone still needs core?
Yeah, some people do that, but it's how you do it.
What type of thing? What do you reckon?
Well, look, if you've got somebody, say somebody in the treatment room, if you're assessing them, and you can actually change, you can change their symptoms by activating their core in inverted commas, and that changes their symptoms in a positive way, then I think that's a good indication there probably is some sort of fatigue element there you need to go away and work on.
Yeah.
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 But see, if you've got somebody that's got a real stiff extension-based spine and the retrospinal like iron ropes, I'm kind of thinking
Yeah.
I'll be the one I want to do that with. Then you
No.
need that opposite way.
No,
Depends if you can change symptom stuff out.
absolutely. So it's all that same, it's like, it's symptom modification, but not necessarily using manual.
Yeah.
So you don't have to use manual. You can use like some slight hands-on strategies, but you're not doing like treatment per se. You're not like putting them in prone and moving them. So I'll show you some of that stuff now. Um, do you guys ever see this kind of stuff? Like people who are like bolt upright?
Mm.
Yeah.
You do? Okay.
Because everything's supposed to help straight.
That's the thing. He talks about it in the clip. He's like, sit up straight. Everyone's told, sit up straight, sit up straight, sit up straight. It's like, well, not necessarily. It's like sometimes people should sit up straight, other people shouldn't.
Was it one of your, or Kieran? I saw a video on social media. I think it was a Perth physio talking about that. And it was like, studies show people with back pain tend to have better posture anyway, because they all were sitting upright and stuff.
Yeah, that's what's his name? Uh he's one of Peter's little colleagues, yeah.
Little.
Well, he's not little. I think he's probably taller. But it's like um he's on Physio Network. Yeah. And it's true. Um I forget his name. His name will come to me. Um nice guy, important guy, but I've forgotten it. Um so this is this paper that someone alluded to just before. Just quickly. Um, this one. This is a very famous paper. This is another one I can send you. Just remind me. It's basically what we say to the patients stays. How you explain it to them sticks with them. And mostly it's interpreted negatively. So when they have acute low back pain, if they go and see a healthcare provider, if it's not framed positively, the patients will have this negative spin. Some of the communication is quite shocking. Here's an example. Have a read of that. Can you read that, or do you want me to read it out? Not good. All right, here's another one. This one's pretty full on. Maybe a trigger warning. It's pretty full on. This paper shows that the beliefs, so that's why I made the comment about you've always got to at least superficially clear their psychology, because the beliefs are arguably the most important, which is why this treatment planning thing I always come back to, because how we communicate to the patients is what sticks around. The actual exercises are debatable actually. It's more like what the patients remember from our interaction. And also what you believe as the clinician. Because if you believe and I believe everyone should sit up straight, then we'll tell everyone to sit up straight. But if we believe the patients need to relax, then we'll get them to relax. Or just if we think it just depends on them, then we'll tell them that. So the beliefs are very critical, which is what this paper talks through. What do you think are some of the drivers of beliefs in patients?
Doctors.
Doctors?
Doctors say.
Chiropractors.
What do the chiros say?
Realign it.
Realign them, their backs out.
I think it's a cultural belief, like certainly the media sort of driven, whoever's driven the core stability thing, every back needs to be core stabilized. So what people read in Facebook or the news or all that kind of stuff, it's like the health industry sort of what they're driving.
Yeah, yeah. So they call it like iatrogenic, like it's basically a lot of the healthcare systems that have caused the problems.
Also, previous experiences, like what their family have had, like friends, they always seem to find somebody that's had the same thing that had a terrible result or a terrible response. And
Yeah,
then you find the person that goes, "Yeah, I had that, and I'm great now."
yeah, yeah. It's crazy. It's like more with patients, like I've said to you with the ACL, with patients, it's less about like science. They're more about like what their neighbor had or what their family member had. Do you know what I mean? With clinicians, it's often what the other clinicians have said or what they've seen on social media now.
Sort of relatively fatalistic, isn't it?
It is. It's kind of negative.
Yeah.
So this cognitive functional therapy is what we do a lot of here in Perth. Okay? We do it cognitive functional therapy. How we think can affect how we function. And so we ask the patients questions about what they think about their problem, and then we try to change their function based on that. Some of the physios, like what do you guys think is more important to change the patient's cognitive factors or change their behavioral and functional factors? Could be a trick question.
But if you change one, you're going to change. You may change the other.
Yeah.
I would argue that if you change their function positively, I think their effective component will change dramatically first, as opposed to the other way.
I think you're right. The problem is a lot of physios are trying to convince the patient.
Can I put a caveat in that?
How do you mean?
I think it also depends on the individual that's delivering them.
The therapist?
It's delivering them. So if you do it, say you want to change the cognitive component before the functional, I think it might depend on the individual that's delivering it. Because like Peter Sullivan, you with your back,
Yeah.
story of a friend of mine who had a disc bulge and then S1 radiculopathy.
Yeah.
And it was still hanging around. This was probably resolving, but the S1 radiculopathy is still there. Went to the David Butler course, listened to the David Butler course, listened to David Butler, and came back relatively pain-free.
Yeah.
And it was like, you know, and it was, I'm pretty sure it was the person that delivered it in the environment, and it kind of just obviously flicked whatever switch it needed to flick out.
I think that so like one of the key points of this talk, and if we do a follow up, is basically you've got to be adept at both. So you can't just some physios will go all functional, which is probably my preference, but you some patients need to be convinced. So I needed to have my beliefs shifted because they were inaccurate, and that then affected my behavior. Some patients you can spend forever and a day telling them that the spondylolisthesis is asymptomatic. But unless you prove it to them, you show them that you can take away their pain, they won't believe you. Do you know what I mean? So when I'm working with a patient, I'm always thinking, do I change, do I go for more educational here? Or do I just screw the education and just try to shift them? Like it's kind of like Bobath versus functional for neuro. I had this one neuro tutor who would come and see us one week, and then the following week we'd have a motor control tutor. The Bobath therapist was like everything has to be perfected. Everything has to be first corrected. Then we progress. Sort of like Pilates pre-functional, then we progress. This other tutor, this chick had just had a stroke on the stroke ward. She goes, nah, screw that Bobath. Let's just get him up walking. And she got the patient like walking down the halls of the neuro ward, and they had this massive limp. And they were like, and she goes, no, let's just get them going. So sometimes it's like we can get too caught up trying to make it all perfect and get the person's pre-programming all tight, but we may be wasting our time. So there's good research for CFT. I'll show you some stuff now. Basically, if you want to dichotomize it for sitting and bending, which we'll spend a bit of time going through, we'll do the active extension group first, right? The long and the short of it is there's some people who hyperextend. Here, this one. There's some people who slump too much. So if you want a really basic summary from today from the physical testing, you want to determine if the patient is too extended or too flexed, both in standing and in sitting and bending. Multiple studies have shown if you can subclassify them, you'll get their pain better. And you give them the exercises that target more relaxation, so to speak, or more lumbar lordosis, if that's what they need. Okay, I'll show you. So, where is it? When I'm doing it, I watch the patients as soon as they walk in. And I'll even say that to them. I've been watching you as soon as you came in. I've been keeping an eye on how you hold yourself. Okay. And then when you're running the subjective, you obviously want to try and tie their functional aggravates to what you're then going to go assess. The key question I ask them is, what is your number one thing that causes you pain or you most avoid? Okay. When I'm going to correct them, sometimes they'll catch it straight away. They'll like get it in weight bearing. Other times they won't. They'll like, you need to regress them. You need to take them into a pre-functional position. Sometimes I'll film them and show them on their phone, corrected, non-corrected, and I'll compare the two. Sometimes I'll put pressure through their shoulders and show them, which we'll go through with you guys. Sometimes I'll get them to touch me and I'll prove them that way. But they might have to do hundreds of repetitions to catch it. All right. So let's do actually the flexion pattern first. This is a patient. I don't think my audio is working for some reason, but here's a patient who had back and leg pain. Okay. When he got to there, it was really sore. I got him to bend his knees. Look how much further he goes. Now I get him to stick his hips out and bend his knees. Look how much further he goes. Then I got him to shift the weight off his sciatic leg. Bend his knees, stick his hips out. He has no pain by the end there. So like the subtle cues can just take away his, but he'd been bending. So he's like what we call a flexion pattern. He was too flexed. So watch how flexed his back is here. That part. Okay. Versus the end. When I get him to like stick his hips out in extension, he gets heaps better. See how much further he goes? So I got him to stick his hips out. So for this is a patient who's like stuck in posterior pelvic tilt, basically. Does that make sense?
Yeah.
So I'll show you some, let's say Dave kind of looks like he's doing it at the moment, right? He's just chilling there, slumped, which is cool. Do you get pain right now? Or are you good?
Oh, pretty good.
Do any of you get pain in sitting now, having sat for like an hour? Stiff? No. So what you can say, you can just get the patient to sit on the edge of the chair. So everyone sit on the edge of their chair. You're kind of already doing it. And then I'll take a photo of them in this position. Right? Then let's do it on each other. Go put pressure down through your shoulders right now. Like, so do it on each other. Get your hands up. One of you stand behind the other person and shove it down hard. Real hard.
Are we supposed to be sitting up or leaning back?
Or just
Slow
like,
first.
so this just put them in provocative position under load then?
Yep.
Essentially,
Yep.
right.
So slump heaps like you are now.
Oh, and then
Put your pressure down through his shoulders real hard.
Yeah.
Just jump.
Where do you feel it?
Go again. Shoulders.
Okay, now sit right back into the chair and then stick your hips out.
What was that?
Stick your hips out.
Forward.
Come show me him from the side, or maybe turn to the side there, Jess, that way.
So sort of do an anterior tilt.
Anterior tilt, but quite
anterior.
extreme.
Yeah.
Okay, now push down through his shoulders.
Yeah.
Where do you feel that?
That more in the back. That sort of hinge point.
But does it feel more sore or same?
Slightly more.
Okay. All right. Switch it up. Switch up the partners.
So would that be more indicative of an extension-based problem then? Like,
So
if I
that'll be someone. Yeah, he's more an extension.
pick-
But these people, when you do this, they're worse. When
Yeah.
when you correct them, they're better. We call that a flexion pattern.
So if everybody's relatively asymptomatic, we're not going to pick up that stuff here.
Nah, you guys won't pick up much.
That's really loud. I never thought.
Yeah. So now, what you can get them to do, so you guys can all practice it. Slump a bit, okay? Now sit back into the chair. And stick your hips out. Jez is looking sore doing that.
Yeah, I was like, that is actually
Let's pick it up, like, actually.
Wait.
Okay. But you don't have to sit up straight. All you have to do is just correct your hips. Okay, and now come out of it. And now let's keep repeating it. See how many you can do. And tell me what starts to happen.
That's fine because we're comfortable.
Is it getting sore?
It's actually good. The opposite. It's actually getting easier to do.
That's good. That's good.
In range sort of like sensations is normalizing out.
That's good. That's good. Now, some patients get a, can you get like, do you guys sell lumbar supports?
Yeah.
Okay. Get a towel, couple of towels. I used to sell a lot of those lumbar supports.
You swap that.
Put that in the small of your back.
Sorry, we've got.
Now relax onto it. Does it feel the same as doing the anterior tilt or not?
Yeah.
I'd say slightly more comfortable.
A bit more comfortable? For some patients, you need to get them to actively correct in sitting. So you have to like show them how to do the anterior tilt. For other patients, they literally just need like a lumbar roll. I sell quite a lot of those lumbar rolls, and it's like a good cue for them to be aware of how to stick their hips out. Now, some patients don't get it, right? Can everyone get a Swiss ball?
Yeah, one.
But our soul football.
You got one.
Yeah.
One.
Okay.
It needs to be flared out.
Have a sit on that, Dave.
It's gonna become Swiss egg.
Now, stick your hips out. Relax it. Just the hips. Keep going. Just repeat it. I sat on a Swiss ball for about 5 years when I was at work because I was like a bit of a motor moron. And now, because I'm a flexion pattern in sitting. If I sit for ages, my back gets really sore if I'm too slumped. If I correct, I'm better. So I used an unstable surface to help me to get more attuned of how to sit, right? But then you can make it a little bit harder. So everyone sit forward on the edge of their chair, or you on the ball, Dave, if you want. Lean forward like maybe 20 degrees. Stick your hips out. Back it off. Keep doing it. Do as many as you can do.
Don't feel I'm getting much more movement here.
Hard.
Yeah. Kind of moving.
Okay, now go back to the slump position. Stick your hips out. Keep your hips out and lean forward the whole time. And now come back, but keep your hips out the whole time. Keep going.
Anterior tilt, yeah.
Oh, okay.
Anterior tilt, yeah. I should be we're filming it today, so we should yeah, we can put this clip up on Insta. Now
People do today.
now lean forward, stand up. Sit back down, stick your hips out, bend your knees, sit down. Keep repeating it. It's a bit hard on the ball. You can shift to the
Watch me say. Oh, go for the shake.
Sit the stands.
But you getting that.
Now shift one leg in front of the other. Lean forward, stand up. Keep going. Now take your front leg off,
Off. Single leg.
but keep the hips out the whole time.
Let's check.
Okay. Now, lift one leg just in the air. Stick your hips out. Back it off. Keep repeating that. Do like 10.
This actually has nothing to do.
Acute entertains himself.
Now do the other side. Lift your other leg up.
Range progression now.
Now have one leg out, like knee extended.
Oh.
Do you feel I'm not coming back to physio? I totally am.
Now do your other leg. Hard.
Not hamstring enough. Sorry. Do
Are
you
your
have
hamstrings caning?
I think I'm right forward. Oh, that's
Now stand up. Slump. Just stand slumped. Lean forward, touch your toes. Come back up. Just do a few. Now stick your hips out. Like anterior tilt. Bend your knees though. Bend your knees as well. Keep your hips out and lean forward.
oh,
Come back up. Keep going. How's that?
Yeah.
Now, stand on one leg. Bend your knee a little bit. Just lean forward. All the way. Come back up. Well, Sophie's struggling there a bit. Keep going. Back up. Now, stick your hip out. Anterior tilt. Go forward. Come back up. Keep your hip out and keep doing it. See if you can do like 10. Where does that change it to?
Hamstring from
hanging.
More hammy?
Doesn't make any sense.
I find it easier.
Now, when you get down to just start it. So stick your hips out and just do a little bit of a lumbar flex. Stop there. Relax your hips off and stick your hips out. Keep doing it. Hard.
not easy.
You guys are pretty good, to be honest. Physios are pretty good. The patients when I do this, no, hopeless. Some of them are like, they don't even get the sitting part. Have you got some heavy weights there?
Yeah.
Can you get like maybe 15, 20s?
Wait, what weight this for? You want a kettlebell?
Kettlebell be good. Do you guys want a break or are you good?
I'm fine. I'm good. You right? That needs that needs more stuff.
Not for exercises. And 50.
All right, everyone grab a weight between 10 and 20 kilos if you can.
I'll be crying.
So,
I just see some big ones. I brought one.
yeah.
My morning's patients come back to me.
What's that?
This is like 2 patients I had this morning. Eh?
This stuff I use so much, like all the time. So this is someone so what I'm trying to do is show you different postures that the patients might get pain in, and you give them an awareness of how to correct their posture in those provocative positions. Sometimes they'll catch it just by telling them a cue. Sometimes you have to kind of put your hands on them. Sometimes you have to strap them, which I'll show you.
Does this kind of work in 2 levels? Like you're getting that lumbopelvic positioning, their awareness.
Yeah.
also sort of like help them find the midpoint, whereas
Pretty much.
you really want to get living, but at the same time, you're going to mobilize them in that sort of
You've got it.
position.
You've got it. This is exactly what we're doing.
Aye.
And so like there's some patients I see on second opinion. Like, to be honest, if they're chronic low back on second opinion, this is the stuff I'm testing. And almost always they haven't been, they're not aware of how to, they're either weak, like they can't do those endurance ones that I'm getting you to do. Like they can't actually hold the position because they're too weak, or they don't know, like they have no idea of how to hold themselves. Like they haven't made that mind-body connection. Sometimes they've been given that nocibic information, but sometimes they literally just don't know how to control themselves. And so that's what I like to show them. Everyone have a stand up. Grab your weight from the floor. Lean forward. Tell me where you feel the effort.
Means.
Hammies?
Yeah.
Okay. Now, back up. Anterior tilt. Lean forward. Tell me if it changes.
Yeah, a little bit in the lower back. Start with.
Okay. Bend your knees. Keep the hips out. Where does it change it to?
I feel it in my back.
Even worse in the back, yeah.
We're all extension based.
You guys are all extension based, maybe.
Just keep deadlifting.
Now, just one leg, go slumped.
One, what?
Single leg. Don't have an anterior tilt.
Oh, don't have. Oh. It's okay. Would it?
What's it like?
Comfier for me.
Now, again, hips out if you can, if it's tolerable.
Yeah, that's worse.
Is it?
It's from hamstrings. I prefer to be posteriorly tilted as well.
Some patients, well, you guys are all one. Seems like you're all the same peas in the pod. But some patients aren't this. They're like this. They find complete relief with that. So typically we'll give patients for deadlifts, you want to try to ultimately, the goal is to be able to lift heavy from the floor, right? But patients might not be able to do it straight away. In fact, sometimes even sitting's too hard. Can I show you a couple of other cues I do for sitting? All right. Maybe, Jez, if you just turn the chair around this way.
That way?
Yeah. Just come forward a bit in the camera. This way. And Dave,
Yeah,
can you go up behind him?
I can.
And can you put your second and third fingers underneath his ischial tuberosities if you guys weren't already well. Now, I know this is probably incredibly uncomfortable. Slump. Stick your hips out. How does it feel different?
My fingers are. She got video evidence for harassment.
So you can say to the patient, sit up onto, because sometimes you go stick your hips out, do an anterior tilt. They're like, what does that mean? So if you put your fingers under there, they can feel that hard bit underneath your fingers once they sit up. In fact, everyone can do it on themselves. If that's not a normal thing you do, put your fingers under your ischial tuberosities and sit up onto them. See how they kind of stick out?
Yeah.
So that's another cue that I'll give patients. And I'll say that to the patients. They'll go, oh, that's what you mean. Now, sometimes the patients still won't get it. They're like, they just kind of do all these weird movements that aren't what we want. Dave, go around to the side. Pop your hands on his ASISs. So I'll get my hands in like this, and maybe the girls, you can do it on each other. Rock his hips forward, like pull his hips forward, like that. So you say to the patient, I want you to roll forward onto your hips.
This is getting a bit bull bathy, isn't it?
It's a bit like bow bath.
Yeah.
But it's like trying to, what are we trying to do? We're trying to find the way to get the patient to make that mind-body connection. Sometimes they won't get it if we just say it to them. Other times you've got to put your hands on them. Now, have we
I
got,
actually find that pelvic tilt, I find it easier with them leaning against the wall and just getting
okay,
them
yeah,
forward.
let's all do that. So go up against the wall. There's quite a few. There's like different positions you have to try to get the patients into.
Did we find all?
Oh,
Some people are just running away from me. Apart from Cat.
Oh, you moved it.
Cat's in final on that.
So you can start off up straight, like really tall. I don't know if this is what you do, Dave. This is what you mean, but you can stand up straight like that. Stick your hips against it. So you can say like push your buttocks into the. Bring your feet away a little bit. Do the same.
So I like that for extension-based back pain. Feel it?
Yeah. Yeah. Now squat down. Do the same here. So in and out. So hold the squat position and just go in and out. Okay. Now go into crook lying.
Sophie's got herself there.
So everyone have a lie on your back.
You come down and change the level here.
Now pop your own hands on your ASISs. Roll, stick your hips out or dig through your heels, like pull your heels up towards your bottom. That's another way you can do it. You get the patients to dig in through their heels or like pull their heels up towards their bottom with their feet flat. That's good. Try sideline. Just feel what it's like. The difference between doing it in weight bearing versus non-weight bearing. Sometimes patients won't get it in sitting. They won't get it in standing. So you've kind of got to have a bit of, I showed you the hardest ones you want to get to, which are more like the heavy lifting. But some patients are not going to get that straight away. So you may have to regress them to this. Or even 4 point. So go into 4 point. And then come in and out. Just not so much the low back, not so much the mid back, just the tail. See how many reps you can do. And you can see how this bird dog idea took off because you're kind of like getting them into that neutral posture and then bringing in the other more extreme elements. Thoughts, Dave? I can see your mind's kind of racing there.
Oh no, it's just I get it.
It's
It's just
good.
like order. It's almost like where you start them off, but it's how you add that to your assessment. Then it's just that sequential. Go like, where's your starting point? Where's your finishing point of the end?
You've got it. Like, so you basically, I think the very good physios can pick that point quickly. But Pilates training classically would be everyone has to regress to pre-functional or non-weight bearing. And they have to master it there. But this cognitive functional therapy idea is probably the reverse. You try to go for their functional ag first and then you regress. Does that make sense?
Yeah. So if you're going to regress it, it's as minimal a regression as you can. It's all how to put it. Say they want to be able to do something on one leg.
Yeah.
Okay, you can't quite do that at the moment, but they're quite happy sort of bilateral stats.
Yeah.
Start either bilateral or offset and then build them up to single leg.
Yeah.
So don't take them too far away from where they want to be. It's almost like taking just before that point where they're having trouble. Would that be right?
Absolutely. You got it. And then you either say to them, whenever you feel pain, I want you to be aware to change your posture into this position. Or I want you to, at home, this many times a day, do this many repetitions. You can either go habitual and try to get them to like use pain as their guide, or you can say, I want you to get into the habit of self-correcting with these many reps. Does that make sense?
Yeah. So for instance, say you've got somebody comes in, flexion-based back pain, and then the pain comes on just around about knee level. But if you're sitting, there's less pain and they get the range of motion is far greater. You can start working those sort of strategies in sitting.
Yes.
And then gradually progress that up to that standing position.
Yes. This is what I do with patients in second opinion.
So that could go like sitting to some sort of perch sitting.
Yep.
Stand.
Yeah. You got it. Yeah. And then I think the skilled physios have a few different strategies. I'll show you another one. Can you guys get some rigid tape? The sitting one's like, when do most people feel back? It really depends, but it's going to be primarily prolonged sitting, maybe prolonged standing, possibly possibly bending or repetitive bending, right? They're going to be your main things. So they're the functional tasks you do. Now, what was that?
Just turn around Jeremy's and get your shirt off.
What do you take your shirt off? What?
That's what I'm saying, mate.
What do you say?
Just said to Jeremy, get your
She
shirt
wants me to whip my shirt off.
Yeah.
Yeah, let's do it, Jess. Yeah. You've got the best rig, so you got to like.
Oh,
I was wondering that Chuck Norris picture you have, is that like your Jeremy picture?
I don't know, mate. Honestly, sometimes the days I'm preparing these PDs, I just like go on these random kind of internet searches. I don't know what I come across. Now, get 2 strips, maybe 15 centimeters. Probably not even that big. Like you can cut that in half. Sit down, Jez, but turn the camera to the side and just tilt it down a bit.
You wanna sit side up that way? Face the general public, Jeremy.
yeah.
Now what's that?
Sit forward a bit. Stick your hips out. So roll onto your tailbones. Split that one in half there, Dave.
In the middle or
Oh, no, you've done it. Put that on just his right lumbar erector spine. Vertical. Yeah. And then put the second piece. Hopefully he's got some stray hairs there that'll stick onto nice and tight.
Don't know. Can I read out what's written on the back of your underwear?
What is written on the back?
Nobby.
Nobby.
I don't want to know. That just sounds weird. I don't know what's going on with that.
Oh, that sounds weird.
Now get another piece and put 2 strips straight on top. So do one on the left, one on the right. So you got 2 on the left, 2 on the right.
What's kind of, what's it?
Yeah.
And you stay in that anterior tilt. This is another thing I'll do, because when he slumps, what's going to happen?
Good tension up.
It'll pull. So he'll feel like this kind of like pulling sensation. Now, just very slowly, like, come out of that position. Tell me what you feel.
It's pulling me back into the.
Yeah. So this is one I do also quite a lot. Can everyone just have a bit of a go with that just to see what it feels like?
So I've used something similar, but I use rock tape. I think to use them extension based ones, if they're erectrospinal are really firing up,
Yeah.
sometimes put them in flexion with rock tape, but put the rock tape down without any stretch. So when they come up, it kind of crimps the skin.
Yes.
I don't know if it has some sort of detoning effect or some sort of peripheral input change in central output idea kind of thing.
I think sometimes, yeah, I do agree. Everyone give that a bit of a go. So sit forward on your chair, sit up tall, and have a feel of what it's like.
Here back, so
Sure, you can imagine what it feels.
we just stand behind the computer and rip tape and make it sound like I'm doing it.
Oh yeah, I can feel that.
So would you be careful, like say with that, say you've got like, if they're really acute, could you maybe sort of, you get the danger of maybe overcorrecting them to a degree with that taping as well?
You potentially could, but that's why you always test them first.
Yeah.
And you try to find like some position
Yeah.
that's comfortable.
Yeah.
So when you're using, if you're using that sort of, right, so you're using the pelvic tilt up more, you've got motor control patient, or a patient you think fits into this kind of sort of treatment pathway.
Yeah.
Once you've got them sort of pelvic tilting, they can now understand where end range is. Are you sort of looking for them at base to get to a point where they're holding like a midpoint and that's where they're living in that midpoint area?
You got it.
Right.
And then it probably takes them. So if you're treatment planning, right? If you look at the CFT studies, if you correctly subclassify them, so the people that are either too slumped or too extended, and you target their strategies,
Yeah.
It's probably going to take about at least 3 months.
Yeah.
In the CFT studies, they see them 8 to 10 times.
So, right, okay, that's interesting, isn't it?
Because because you guys are getting it like that. Like you guys I'm saying it and you're just doing it straight away. The patients aren't like that.
Yeah.
They don't get that straight away. It's like they need to do it like thousands of times. And it's like such a fine movement.
I need to show you that.
Here we go.
Herself.
I don't think it.
What's going on?
No, I'm just pulling the tape off and it made me cry.
Are you serious?
No,
1 year ago, you got somebody vomiting, and today you get somebody crying.
This is like potential workers' comp. This is a workers' comp scenario.
July CPD will become a legendary thing.
That's ridiculous.
Somebody bursts in flames. Right.
It's actually
That kind
ridiculous.
of content there. Once you've got aware of the spinal position, that sort of midpoint is hopefully the sort of, this is where you want to be living a bit more.
Yeah. But then you have to advance them a bit.
So, all right. At that point,
Yep.
is there a population? Because what I would then think is at that point, you almost could become non-specific in your exercise prescription to a degree. Like, even if they're doing that with general exercise, they're going to be getting some sort of throwover.
Well, what you want to do, it's a good question. What you want to do is you want to grade them back to what they're not doing.
Right.
Because almost always, which is something have you guys got a whiteboard or not?
Yeah.
Okay, move over to the whiteboard and maybe someone grab a pen.
This is for Tim. Tim will be missing out. He likes his whiteboard.
Does he?
Yeah, Tim at the moment is trying to create competitions within the clinic to see where he can come number one.
What do you
At the
mean?
moment, he's had 2 competitions and he's lagging at the bottom of the pile.
All right. This is what happens in so many back pain patients and other patients with pain and injury that is like a cycle they get caught in. Write this down at the top, and Tim can just mull on it later. The fear avoidance cycle of pain. At the top, have pain, but maybe have it in the middle. You've gone a little bit over to the left. That's all right. We'll forgive you. Then down, yeah, just write pain. Then down to the right, have, yeah, just like a circle. You can draw a circle if you want. Big circle. Yeah, down there, write beliefs. Below it, write catastrophizing.
Fine. S or Australia.
That looks all right. Then write underneath pain, but down the bottom, like below catastrophizing, write fear. Up to the left, write avoidance. Then write abnormal above it, not quite that high. Write abnormal movement. Then above that, write disability. And then I want you to link them all, like do little arrows between them all.
Wait, all.
Yep, like no, just like kind of like in between each word. That's it. So I had a patient with this yesterday. And I said to her, because what had happened, she'd had an injury and she started feeling pain. Her GP told her to not put any weight through the area. She did that for 4 weeks. This is a mild sprain. She came in, she was super scared. Arebro super high. She'd stopped bending, squatting, lifting, bending. On and off the floor, wasn't doing it. Was scared. She was scared to move. When she moved, she was super stiff. And she was essentially disabled from where she was. She would stop working. And then it fed into more pain. Her pain was no better. She'd had it for 3 months. Do you guys see this a lot in clinic? Or not?
Sometimes. Yeah.
What I do is I write that out for the patient. I'll write it out and I'll show them this is the cycle that you're caught in. And now get a red pen, if you got one, and draw a big X through it. The whole thing. I'll say, we've got to stop it. We've got to stop the cycle. And then I'll say to them, we have to grade you back to what you weren't doing before. That's how we fix this. And I said that to her and I said, does that make sense? She's like, yeah, that makes complete sense. Because the patients will see that they're kind of stuck and they've learned all these patterns that are unhelpful. So this is like a mix of that psychology with their physical fear avoidance. Does that make sense? So in essence, Dave, you want to get them to do the things that they've been scared to do, but in a safe way. Now, eventually they have to do it automatically without thinking twice. But that takes that takes lots and lots of reps and probably months of training if they're particularly chronic. Any questions on that?
I suppose from that point of view, if you've got a client like that, the good thing about this is you can kind of set the scene for them at a treatment and going like, in 3 treatments or 4 treatments time, this is what we want to be able to do.
Yeah.
You can use this to your advantage where you can actually map out their recovery, can't you?
Totally. And the thing is, there's now control trial evidence that this works.
Right.
This is not like just some token Pilates program or something. It actually, if you use this type of philosophy, the patients will get better. A lot of it comes back to the confidence of the clinician. Now, everyone go sit back down. I'm going to show you the opposite one. Okay, everyone get their fists like this. Tense it as hard as you can. Real hard. Like just squeeze your fist, basically. And then move it down and up like this. What's that like?
Stiff.
Yeah, that's fluid, doesn't it?
Stiff? Now let it go floppy. Which one's easier? So can you see how some patients get locked in this idea that they have to keep their back rock solid? So I see some patients and they're doing that like a block in their back. So everyone sit up straight, bolt upright. The thoracic and everything. Now, sit back into the back of the chair. Let your tummy out like a gut, if you've got one. And then slump fully. Pop your arms on your thighs. Breathe in through your nose. Out through your mouth and just chill. So these patients, you have to do almost the opposite to the lumbar tilt. You've got to give them permission to slump. Some of them have no idea that it's actually okay because I've had some patients been told to sit up straight since they were in their teens. And then you go, where's your back sore? And they're like, point to their erector spinae. And you go, well, why are you sitting up like that? And they go, because I was told I have to sit up straight. And then I'll go, well, just relax your back. They're like, that actually feels better. But they'd never made that connection. So for some people, they're actually overshooting, which is kind of what you were alluding to before, Dave. Like, so you've got to be careful because if you give them the anterior tilt, it should be moderate, not like all the way up where everything's jacked up straight. Now, the next thing you can start to do is, because a lot of them will have pain, say, with sit to stand. So everyone put your hands on the inside of your legs. Head down like this, like right down. Slump down to the ground. Let your hands come down the inside of your legs. And come back up. Keep going up and down. Now, just lift your hips off the back. So when you lean forward down to the end, so slump all the way first and just lift your hips up. That's it. And back down. Yeah, you're doing it right, Sophie. That's all right. Go forward and then just lift your hips up. Yep. And then come back down. Keep repeating it. Now, lift your hips right up in the air. Great. Back down. Keep going. Okay, now go all the way up and stand up. And repeat in reverse. So bend your knees, slump, and sit down. Keep going. Nice. But make sure you keep breathing. Now, go staggered, one leg in front. You got it. Now go one leg. If you can. Now, everyone stand up. Pick up the weight, but pick it up slumped. When I tell gym trainers that it's okay to slump when you pick something up, they lose their mind. They actually start freaking out. They think I'm rogue. But for a lot of patients, having a slump back is actually more comfortable if they've had pain. So the lifting technique is based on like physics as opposed to what the studies show. Physics says I should keep my hips hinged because that will take the pressure. The studies show it depends when it comes to pain.
But lifting techniques also based on performance, so the performance related to it.
Yeah, like we're talking, athletes, but the general population aren't so much like that. So there's some patients, everyone stand up. Step back a bit so you kind of can lunge forward. There's some patients I'll get lunge forward on one leg, bend your back knee as much as you can, step back. Do like 5. Now, slump. Drop your head down. That's it, Dave. Where do you feel that? Does it change it?
More like
Now do your left leg.
if you're more extension based, you can light and flex.
You would like this?
If you're extension based.
Yeah. There's some patients, Dave, where you do this and they're like, all my pain's gone. Like it takes all their symptoms away. Now try and load it up. So lunge forward first without slumping. So grab a weight. Maybe hold it like goblet style.
Do you reckon some of that's an element of distraction as well?
I think part of it is probably just changing it. Yeah, giving them a different cue. So everyone go upright, lunge forward. If your legs are tolerating.
I believe it was Casey slipping back.
Now, slump. Head down. Like drop your head down like this. Where does that feel? How does that feel different?
It's like I feel my front leg.
It changes it away from your back, eh? Like more into your like glute or thigh. Now, there's some patients, even when you give them full permission to slump to sit to stand, they keep freaking going up like that. because it can be just this ingrained thing. So let's say Jez didn't like the way that Dave was palpating his ischial tuberosities before, right? And he thinks he's gonna now stab him with a knife. So Jez, if you stand up, walk over to Dave and pretend you're gonna stab him with a knife. Go at him. Like you're gonna hit him with a knife. What do most people do if you're gonna go at them? They brace. So a lot of the patients get this kind of like autonomic, protective, hyper. Like it's like so that in pain science they talk about the volume dial has gone haywire. Like it's like instead of like a stereo, a car stereo, like being at 1 or 2, it's like always up. So I'll say that to the patients. I'll go, what's happened is your body is like primed for a pain attack or a back attack. Like it's like they think something's going to happen, but it's like there's nothing wrong. You just have to let it relax. Sometimes they still will keep doing it with every movement, that hypervigilance I said before. So they'll kind of like brace to bend, they'll brace to stand, they'll brace to sit. So what you have to do is regress them again. Sitting doesn't work. What's the one I do? I get them into supine and I'll show you what I do. So everyone, lie on your back if you can. Okay. Hands on your tummy. Close your eyes. So this is what I'll do with patients. Just everyone breathe in through your nose for like 4 seconds, out through your mouth for 4 seconds. Just do it for like 20 seconds. And this is what I'll say. In our mind's eye, we have an image of our body. It's typically like a black sphere shape of what our body is perceived like. What I want you to do is I want you to trace from your head down to your neck. I want you to just visualize that part of your head that you can see in your brain and go down to your neck. And then I want you to go down to your shoulders. Keep breathing. And then I want you to go down to your mid back and just stay there for a bit. And now what I want you to do is I want you to describe how you see your low back. So you can all do it. You can shout, you can kind of call out now. What do you perceive your back to look like? Give me colors, shapes, size.
I can't picture it at all.
Oh, that's bad.
The devil coming.
Extremely so if it's Jez, it's extremely muscular, white, moderately hairy. No. No. Most patients will say red, jagged, fiery, big. Some patients might say, I see nothing. It's a gap. So what you want to do is say, I want you to just keep thinking relaxing, keep softening your back. Think about relaxing that area. And I want you to see if you can change the shape of it. So you'll say, okay, I want you to just imagine it being more blue than red or more white than red. And I want you to see it forming into soft shape. and just keep breathing, and then go back up to your thoracic, the mid back, and now come back down. Okay, everyone stand up. We'll sit back up. So that's body scanning. That's one of the strategies I'll do with people who are just too jacked up. I have seen it a bit, like where they've either had, say, failed surgery or persistent back or possibly early childhood trauma, or they've had like excessive training on core and they're just bolt upright and nothing's really getting through to them. That's some of the strategies. It's like a mindfulness / relaxation strategy. And I have seen that work, but they might have to do it. I've also seen it flare up patients. If you're just getting them in supine and they flare up because you do it too aggressively. So you have to like kind of calm your phrasing down. You have to be sensitive to the person because sometimes they're all jittery. And if they've had like, say, sexual abuse or something, it can actually like get them triggered. So you sort of have to pick your patients really. But there are some people that they need alternate strategies other than just trying to do things in function. So much like the anterior tilt example, you have to kind of find a position of ease that's comfortable for them to work on. And then it might be that they can do sets and reps of this, maybe 10 minutes in the morning, midday, night, and they're like trying to obviously do the breathing control and relax their muscles, but then they can think about letting the image of their back relax as well. This can help for some of the more chronic cases. What do you guys think about this stuff?
If it's what we're starting doing anyway.
It's probably stuff that you might be doing, but there's just maybe some other tricks that you could use.
I think it gives it a bit better structure, actually.
What's that?
So what we're doing is just a better structure, and probably there's a few more sort of tools and progressions we can start using. It's just a different way to look at it.
That's what I was hoping, because that's basically what I didn't really have like a set structure for it. It was more like a bit, I didn't really know where to put people or how to place them. In essence, you got to work. Is this workout? Is this person overshooting or undershooting? There's a bit more to it than that as well, which maybe we can talk about next time. Where, like, say, if they're standing more and their pain's brought on by standing, that's a bit of a different strategy, which probably takes like hour and a half. I can show you. But these ones, once you try it with patients and see, kind of like that SIJ, some of that SIJ stuff we did, like try it and see, and you'll probably find there's some patients who fit these categories. And they're not necessarily going to be better with more aggressive course, quote unquote, you know? Any questions, comments?
Yeah, that was good.
That was good. Thank
That helps a lot.
Is that helpful?
Yeah, I'm just going to write stuff down now.
I'll send you the recording and I can send you the notes. Just remind me. Some of those articles are really good. They're like, it really gives you confidence as the therapist, but also you can even pass on some of the information to patients. And I think they might not get it fully from you, but when they hear another person explaining it in a slightly different way, that it'll help
Yeah.
them adhere to the plan.
Yeah. No, that was good.
Yeah,
Continue that on, I think.
that's it, guys.
And Jeremy did for all day. Yeah.
Was he still sleeping there? Is he like?
He's grooming his beard at the side.
he's like looking off. He's like doing this, like. I get teased a bit because I've had a bit of a mustache happening.
Yeah, nice.
Yeah. So there you go.
Oh, man. Great.
Easy topping Frank Zappa.
That's it.
Cool, guys.
Well, yeah, we'll sort of go consolidate that. I think we'll follow that one up again.